Welcome back to Quick Hits, the podcast where we dive into the latest trends and innovations in healthcare technology. In this episode of Quick Hits, we have the pleasure of speaking with Dr. Nitu Kashyap, the Chief Health Informatics Officer at Emory Health. Dr. Kashyap brings a unique perspective to the field of healthcare informatics, having started her career as a primary care physician before catching the technology bug and transitioning into the world of clinical technology and innovation. During our conversation, Dr. Kashyap shares her journey and experiences that led her to her current role, where she is at the forefront of Emory Health's efforts to leverage technology to improve the lives of clinicians and enhance patient care. She discusses Emory's pioneering work in areas like ambient listening technology and the integration of their EHR, Epic, with Apple devices, highlighting how these innovations are helping to streamline clinical workflows and documentation. Dr. Kashyap also provides insights into the evolving role of health informatics, particularly in the wake of the COVID-19 pandemic, and how her team is working to balance crisis management with a long-term vision for the integration of cutting-edge technologies like artificial intelligence and machine learning. Additionally, she shares her thoughts on the challenges faced by smaller healthcare practices and the importance of interoperability in delivering comprehensive, patient-centered care. Please don't forget to follow us on your favorite podcasting platform and enjoy this episode. And welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host and CEO of Health Data Movers, Tyler Smith. How are you today?
Great to be here, Ken.
Great. Hey, great to have you as always. We are talking to Nitu Kashyap. She is the Chief Health Informatics Officer at Emory Health. Nitu, welcome to Quick Hits.
Thank you, and I'm glad to be here.
Yeah, we're really excited to have you. I know we have a lot of great questions for you, and so we're looking forward to the conversation. But before we get into that, we were hoping that you could kind of tell us a little bit about your background. How did you get to where you are now as your current role as the Chief Health Informatics Officer?
Absolutely. So it didn't happen by accident, or maybe it did. I will tell you the story. So I'm a primary care physician by training, and I started practicing in primary care and somehow caught the technology bug and took on some roles during EHR implementations back in the day in my first few years of private practice, first at Kaiser and then in Massachusetts with a multi-specialty group practice then called Fallon Clinic. And thereafter, I ended up shifting gears to do a clinical informatics fellowship at Yale and have stayed on this other side ever since.
Oh, excellent. So are you still in the clinical setting?
Great question. That is one of the toughest things I've had to deal with is how to balance a primary care practice with your other role. Both of them end up being 100% of your commitment. And so gradually my practice has dwindled down. I still, from time to time, will precept the trainees and the house staff in an ambulatory primary care setting, but I do not have a panel of patients of my own anymore.
Well, yeah, that's quite the background. And Tyler and I love to have conversations with doctors who caught the technology bug, as you explain it, getting involved, especially in those EMR implementations, because they're so involved. And really, I think that's how we've learned so much about the clinical side and the perspective of clinicians when it comes to these EMR implementations. So Emory Health, you guys have been at the forefront of health informatics innovation. Could you tell us a little bit about like some recent projects or initiatives that you were really excited about or things that you're excited about in the near future?
Absolutely. This is my favorite topic to talk about. Ask me that anytime. So I joined Emory a little over 6 months ago, and part of the reason that I was drawn here was the immense energy and the forward thinking that I saw in the leadership and everywhere around. And to date, I am yet to find anyone who feels otherwise. There are lots of things happening in innovation, in education, research, healthcare, but I'll talk to you about the ones that I'm most excited about in the informatics space. You may or may not be following that part of the literature, but there are things that we have adopted as early adopters to improve the lives of the physicians and nurses on the front lines who serve the patients that we're all keeping as our North Star. And one of the technologies is using ambient listening to help doctors document their notes better. So as you know from each of your backgrounds, that clinicians tend to spend a lot of time documenting what they did in providing clinical care. And there are multiple reasons for that. And we'll stay away from the topic of whether or not it should exist. But let's just, for our purposes, say that it needs to continue to happen so that we are documenting clinical continuity for our peers, sharing our notes with our patients, as well as using them for payers and for billing purposes. So lots of purposes they serve, but the accuracy is important, and capturing the discussion and the nuance of that patient-physician relationship is just so core. When you use templated notes even when we were on paper, is just tedious to capture that richness. People started using voice recognition and other things, and that helped some. We all went to EHRs and learned typing. Some of our users and faculty had to relearn how to work in an electronic setting and rejigger their workflows. And so documentation was one of those things that is a burden that they carry. And we were one of the first organizations to try the ambient listening technologies that allows an application to listen into the conversation between the patient and the physician and be able to parse those as coming from one of those two or more entities, and then be able to put it into a structure that we are all used to and taught from med school onwards. And every providers have used it has found that it's improved their life and their interaction with their patients. So not only is that improving lives for our physicians, but also the patients that we all serve. The other thing, again, feel free to geek out on this one, is the ability for us to launch our EHR directly from an Apple computer. And why is that important? Because our EHR today, and for your listeners, Emory uses Epic. And so we use that product, and it is driven through a separate application, which adds a little bit of time to launch it, and sign on and sign out become a little tedious. When you're launching directly on a Mac device, which was never available prior, you're now taking the EHR efficiency and then marrying it with what some of the Apple products usability add to it. Still in the growing phase, but the more we deploy it, the more we learn what users like about it and what they would want more to come out of it. So our focus has certainly been, if you can gather my drift, been on improving the lives of the people that we serve.
Nitu, it's awesome to chat with you. And, when you're talking about launching Epic out of Apple, it makes me think a lot about when Excel and Word were available out of Apple, which was a big turning point, in the Microsoft Apple wars back in the day. But there was another comment that you said that I found really fascinating. You essentially were using computers and technology, but then when you were trained in medicine, it was still in the paper world. And so you moved out of that. And then you were around when we did the big shift. What I'm curious is, as now technologies like Abridge and DAX and Ambient are available as this next generation of physicians is being trained, how do you see that affecting the practice of medicine and actually how clinicians are learning to practice medicine?
Great question. And we dwell on that quite a bit, and not just for the clinicians, but also for the trainees. As an academic medical organization, we are responsible for training the next generation of healthcare providers. So it is a huge part of how we discuss not just these technologies, but others as well. Are we enabling the clinicians of the future to understand and use these technologies and tools responsibly? We never send a physician out into the world to practice without knowing what a stethoscope or what an ultrasound does. And we shouldn't be sending them out without understanding what these technologies offer and where they are reliable and where they should be used with caution. So it's a huge part of what we think about. And I know I gave away my demographics a little bit when I said we still were on paper when I was in med school and in residency. But yes, we all learned to pivot. What I also saw happen in the past 2 decades is that the people who were efficient were just efficient no matter what you gave them. It took them a little time, but they figured out their way, and they know how to make the flow work. Mm-hmm. And the people who couldn't get the workflow on a paper also won't be able to do very successfully in an electronic system. If you take bad practices from the paper world and you hardwire them in an electronic world, but now you've hardwired it, there's no give. So you'll see good practices get magnified, and so do the bad practices do. And those are the kind of things that we watch out for. And that's how, in some ways, the field of informatics evolved and started. We sit at the area between medicine and technology, that's clinical informatics. And that's part of what we do, is how to make technology best serve the clinical mission of the individuals of the organization. And that can take many shapes and forms. But the key is, how do you learn newer things? Because these aren't the only things. Like, when did we all get exploded on the marketplace with generative AI technologies? I think it was November or December of 2022 when we started to hear about those things. Mm-hmm. Those of us who've been using predictive models and AI for some time, even we were excited about it. And we certainly saw the hype cycle, and now it's a little bit of leveling off. There are everyday newer things that are happening. Let's not forget the biggest one in our lifetime. Let's hope every dark cloud has a silver lining. COVID happened, and we learned how to make a whole new variety of vaccines. The work had been going on, but it forced us to close that work and bring it to a closure. And now we have a whole new way of making drugs and drug discovery. So there's always going to be a new thing, and keeping pace and distilling out the principles behind those, that's what we're looking to take to our trainees. I don't know if I answered your question or got overexcited, but let me know if I need to rephrase anything.
No, that was perfect.
Yeah, Nitu, you brought up COVID-19, and it was such, I was thinking about it the other day. We think about the pivots and the changes in healthcare IT, and usually there's, slow curves. But COVID-19 kind of brought everybody to a screeching halt, and then you saw organizations quickly try to get up to speed. So I'll ask you the question of how the role of health informatics evolved in the last few years, starting from that point, starting from COVID-19, mm-hmm. in your eyes or within your organizations.
Yeah. So I've been I was in the thick of it at a different organization in the Northeast, and now I'm here, and we still have references to the time of COVID-19 we did something. And right now, even in these past few days, we've been dealing with a nationwide intravenous fluid shortage, and people are referring back to the time when we had to do something during COVID-19. So it has left a huge impact on healthcare, and those of us who are in that space. And health informatics was no stranger. In fact, I think what it has done for health informatics is allowed us to showcase what we actually bring to the table. And it's no longer, here, I have an idea, go make it happen. We're partners, and we're collaborating, and we're leading from the front in a lot of different ways. And COVID-19 allowed this cohort of people to actually showcase what they're able to offer in terms of change management, problem solving, asking the right questions, gathering information and processing it, and turning true information out of some data that you have. And a lot of different examples. Almost everyone can start to think about one or the other things where they saw something like this happen. It did a lot to bring the field into people's forefront. And I just happened to be at the right place at the right time. And people in my cohort are able to see the difference on how it's evolved.
That's an interesting perspective, especially I appreciate what you mentioned about now being able to showcase the value that's brought, because the value for health informatics has always been there, but it was always kind of just seen as an aside. And now for you to kind of be brought into the room sooner, right, that allows you to have even greater value. When it comes to kind of just the practices that arose because of COVID-19, are there some things that have now been kind of abandoned because you're no longer in that everything's on fire mode, or has it pretty much
Yeah.
been pretty measured, would you say?
I'd love to be able to answer saying not everything is on fire, but the way healthcare systems are working, everything's on a different fire every day. There's budget mitigations,
Mm-hmm.
there's pairs cut, there's payment cuts, there's shortages, there's drug shortages, there's staff shortages. There's there's a different level of crisis around us, and so um, it it just feels like we probably have learned some lessons and know how to react to these things.
Mm-hmm.
But to me personally, it just feels like we're we're constantly in like from one churn to another.
Mm-hmm.
I mean, think about it, whether it's a Change Healthcare outage that impacted nationally,
Mm-hmm.
or a CrowdStrike event that was an international event.
Mm-hmm.
Now we have another national event with a fluid shortage that no one anticipated. And in all of those areas, health systems are just getting pounded. And I feel for my colleagues who are in private practice who do not have a system that can sort of provide the backup for them.
Mm-hmm.
It's interesting. There's that quote, never waste a crisis. But to your examples, healthcare is always in crisis. The COVID-19 was a crisis that everybody found out about. But it sounds like that's actually the status quo in healthcare organizations, which it's really interesting because, when you're talking about being reactive and adapting, sometimes that can make it harder to then focus on like a roadmap or ensuring that, maybe more of a future looking plan is implemented. And it makes me curious about, with AI and machine learning, how do you all
Mm.
plan for how we've talked about ambient, but, ambient is one piece of AI. There's so many other
Hmm.
pieces. So
Hmm.
how do you
Yes.
balance like setting forth like a longer term vision with understanding there's always going to be these crises, or maybe there's a way
Yeah.
you balance the two and you use one to push the other one forward?
That's exactly how we do it. It's a balancing act. And while COVID-19 was one once in a lifetime event, we hope that everything stopped and we had to pick up the pieces one at a time. I don't mean to sound like it's all doom and gloom in healthcare. There's a lot of good that's happening. There's a lot of new life-saving drugs people have found. There's new procedures, processes. There's so much more that we can offer today that we didn't have even 4 years ago. So it's not all doom and gloom in healthcare. And the way you do that is exactly balancing. And one thing we've learned is that if it's not one, it's the other. Be prepared and plan for having a crisis on hand. And what distinguishes a strong system and place, just as it distinguishes strong character from another, is how you recover from it. Were you prepared enough to react quickly, swiftly, understand the problem, have a mitigation, and then be able to get back on your feet to move forward to the next way? It requires courage, it requires quick decision making, and it requires preparedness. So being proactive, preparing, everybody talks about, I'm not a sports person, but I'll give you a sports analogy.
Sure.
Everybody talks about the goal that was scored with a 9-foot jump, but people forget that it took years of practice anticipating and training for that 1 microsecond and anticipating where the ball is going to be,
Right.
not where the ball is.
Mm-hmm.
And I think that's how we have to learn to structure ourselves.
Yeah, and it's really interesting to hear you talk about different aspects and, courage. No organization has the monopoly on courage. So when you talk about, your colleagues or friends at private practice or smaller organizations, they can have just as much courage as those at Emory. But there's something you said about
Absolutely.
resourcing and having
Hmm.
more access to resources, and it's a trend that we see happening more and more. And I know with Emory recently, expanding with the Houston acquisition, can you tell us a little bit more about, the M&A strategy that seems to be playing out across the majors and all major markets, but then how that the integration process is going from a health informatics perspective as organizations, acquire other organizations.
Right. Big question there. So if I lose track, just bring me back
Sure.
home. Let me just say, courage is not anyone's proprietary thing. You're absolutely correct. Uh, and when you talk about resources, I want to just make sure we understand it is not about the bank balance or your endowment that you bring to the table. It's the people resources that we have, that I feel very fortunate to work with a team that backs each other up. The part that the smaller practices will often not have access to is to be able to flex their resources because they're already so far stretched thin. So let's just make that clear, that resources come in many shapes and forms, and our most precious resources are the people we work with. The next part of your question was, strategy, and specifically, I guess Emory's and yeah, Houston Health partnership. Now, that's a letter of intent. It still has to go through the necessary approvals and due diligence process. So I will just start by caveating that. Why is that an important part of Emory's strategy? So if you think about it, Emory's presence is in the Atlanta metro area, and then in some international areas. Emory has presence in India and the Middle East. What it doesn't have is presence in any other part of the state. And where is it that we can actually take the values and the expertise that Emory as an academic health center brings and take it to an area that serves the people who serve this country? And Houston just seems to fit that bill. That area is an Air Force base. Their families live there, and it's it's a community hospital that's proud to serve those who serve. And we're just happy to be able to partner them and bring the world-class care that Emory can provide to those areas.
Love how you recognize people as the most important asset,
Mm-hmm.
and also, especially making sure that our service members have the proper access to healthcare. So very, very uplifting answer to that question. In a lot of ways, I think that when we have these conversations, we do geek out on the technology, but it's we can't do any of this without the people that make it happen. So yeah, thank you for that answer.
You mentioned private practice and the challenges specifically that
Mm-hmm.
that these small private practices face. What small changes can some of these practices implement that will kind of bring about some of those quality of life improvements that aren't exceedingly expensive, or just a way for them to kind of reinvest in people and not burn out their staff, or the doctors themselves?
That's a great question, Ken. I'm finding myself inadequate to answer this because I was in private practice a long time ago. It was a different world. And I don't know the pressures that they feel. I hear from friends and colleagues, who are doing this, who are having a hard time finding skilled staff. That's the same problem that large organizations are having in finding and retaining skilled staff members. Right. So for them, the problem is a lot more acute because for them to find travelers upends their budget a lot more than maybe another larger organization around the bend. All I can say is we're here as partners, and we all serve the same
Mhm.
mission.
So Nitu, data interoperability is a key focus in healthcare. And can you talk to me about the steps Emory Health is taking to ensure seamless data exchange across its systems?
That's a good question. It's near and dear to my heart. I give talks to the public health people and the clinical informatics people about interoperability and why it's so important. Once you know that the data sources that you're using, the downside and the limitations of those things, you want more of it. And in order to take care of patients, with only half their information, that's just what's happening. So people now have a choice of going to a variety of different physicians, a variety of different places, and sometimes it's not a choice. They're forced by the payers due to narrow networks and whatnot to go from one doctor to the other. And for us to be able to take care of those patients with only part the information is just really, really hard. Also, keep in mind that medical care has gotten more complicated over time. So the number of medications that you have to treat diabetes, for instance, you all watch the news, you know the meds that are on the TV, but those have just doubled even since I went to med school. So the care has gotten more complicated and has gotten more fragmented. How do you bring it together? And the interoperability that I believe this is the only country that talks about those kinds of things, of data sharing and the trust framework to exchange data in the context of care. I would encourage us and implore us to push forward on that, because what it's doing for us, it is promoting care from a visit to visit basis. But what happens in between visits, which as a primary care physician, it is still my responsibility to provide the best of care that we can, despite the fact that you may not be sitting in my office in front of me. I'm still responsible, and I still have that responsibility to take care of you, but I don't have that data because our current interoperability rules don't allow it. So while it is a great thing that has happened in our lifetime, and it was made possible by having data digitized to the implementation of EHR, as painful as that was, that was the whole reason why we did that. And now we have the ability to exchange data, but it's falling short in areas where we have to take care of populations and not just individuals. Take care in between visits rather than during visits. We're also needing to accommodate better any remote physiologic or device data monitoring. That's not accounted for. Let's not even forget research. That has been off limits for using data coming out of interoperability setups. So there's a lot of opportunity. There's lots of good happening, but we still want to look at and make sure we're keeping a line of sight on the opportunities. What's Emory done? I mean, the usual stuff that everyone does. We have those tools and techniques available. We are part of the interoperability networks, and we were one of the first organizations to sign up for TEFCA, and we just wrapped up that build. And TEFCA is an acronym I can probably never remember to say what it is, but it is a framework for sharing information across information sharing networks. So it's a network of networks, and it allows us to even more broadly share in a secure and safe manner information and health information. What else have we done? We have some other tools that we provide to our clinicians to help with data that is all piggybacked on the same framework of interoperability. We have services that are able to nationally provide us data on if our patients were seen outside of the state, for example, or in another hospital. We have the ability to be notified of that visit and be able to, through those same safeguards, obtain information for care where needed. Does that answer your question, Tyler?
Definitely. And quick plug, we have a great episode of Quick Hits where we go deep into TEFCA with Ron Carson of Nebraska. So those listening at home, feel free to move to that track after this excellent podcast if you want to extend your listening pleasure.
Yeah, so Nitu, looking ahead, what emerging trends in health informatics do you believe will have the biggest impact on the future of our ability to deliver great care to patients, as well as taking care of our precious resources of physicians and clinicians?
Good question, and a very timely one. And I will tell you, this will also show my bias as a tech affiliate. So if I say my first thing that comes on the horizon is artificial intelligence and generative AI type technologies, we're already seeing them, much like in every other industry. There's a lot we can do. We are a little bit more cautious than some other industries might be because we have lives and health at the other end of it. So a lot of where AI is being applied is where we're seeing busy work happening, whether it's on the operations side by staff or by clinicians. I mentioned ambient listening as one of those examples, but there are other examples where AI is being applied. Also, as an education institute, things like is information retrieval getting better, or are we training our trainees with the right tools, keeping in mind that the job market they go out to might require different skills. So is a game changer in a lot of different ways, including research on it and by it. And then the caution that comes with it is, the usual things people talk about: hallucinations, authorship rights, copyright privileges, and so on and so forth. So yes, I'm so cautiously optimistic in that this will change healthcare in more ways than we can imagine at the moment, compared to some of the other technologies that have come in the past 5 to 10 years. What is also happening is that distances are getting wider, but technology is bringing us closer. So remote visits and remote patient monitoring and physiologic monitoring through remote mechanisms is becoming more and more positive. You had asked earlier about what did COVID-19 change? Well, COVID-19 took our telemedicine visits from like 10% to 60% nationally, and most organizations saw the same curve. It did come down, but we're continuing because the avenues that it offers and the technology innovation that happened during that phase continues to happen. We're also seeing a lot of trends on workforce transformation. So the skilled people are somewhat choosing early retirement. That's most evident in the nursing workforce, where skilled nurses are choosing early retirement or are working and as travelers. And then the newer people on the floors don't have that much experience. So supplementing their skill sets with a virtual nursing type of role, which again, Emory is at the forefront of piloting as well. So that workforce transformation, same thing I would say for our residents and house staff, the emerging technologies. The payer landscape is changing. There's payer cuts, there are prior authorizations and denials. Those have been in the news of late. Prices of drugs going up. As much as there's new drugs that are coming out on the market, which change the landscape of diseases like diabetes, we have those affordability questions. And then you had touched on strategies and consolidations earlier. I see those continuing to happen just because of all of these market pressures. People are trying to leverage economies of scale, so that it seems like will continue to happen as well. Did I get to your question?
Oh, did you? Yeah, no, that was. I think that was a great answer, and it was a great way to end the call. Really, thank you so much for your time. I know you're dealing with a national shortage of IV solutions, and so that's definitely requiring a lot of your focus. But I really appreciate you being willing to come on and have this great conversation about health informatics and just where it's been and where it's taking us.
Well, thank you. I really enjoyed the conversation, and it was a nice reprieve away from some of the work that we've been doing the past few days. So thank you for that opportunity.
Yeah, no, this was amazing, Nitu, and would love to have you back at some point too to talk about the changes in the landscape with the payers, especially maybe go a little deeper on some of those points you mentioned about prior auth, and then even what this all means for
Ooh.
the patients now with interoperability. So, yeah, amazing conversation, but I feel like we could go for another couple hours, and so we'll have to have you back for a sequel episode. Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.